Okay, hey doctor,
Good morning.
good morning. Now, do you pronounce the last name Suave or Suave, or how do you pronounce that?
Well, there we go.
Yeah, I just wanted to make sure I got the pronunciation of your name correctly. How do you say your last name?
Oh, it's Sauve.
Sauve. Okay,
Yeah,
so
the A and the A and the U makes an O, and it's kind of an optical illusion for English speakers.
I see. What is the origin of that name then?
French Canadian.
French
I got
Canadian.
the attitude to prove it.
All right. Well, welcome. Hey, I was reading a little bit about you, and
You
uh,
did.
yeah, just a little bit of stuff, and there's some interesting stuff in there. And I wanted to get into a few things. And so, what we typically do is we just kind of get rolling, and then we'll open it up to questions because I'm sure there'll inevitably be some questions as we have more and more people kind of packing in here. But one of the things I thought was interesting, I saw some information on something called TMS or transcranial magnetic stimulation, and I've kind of got just a sort of a passing bit of knowledge about that. I know that we're seeing some transcranial electrical stimulation being done to improve performance and other brain outcomes, I guess. Can you just maybe just kind of briefly mention that, and then we can talk about some of the other stuff with diet and things of that nature.
Absolutely. It's so transcranial magnetic stimulation therapy, FDA approved for depression, is it's sort of in the same, like it's written about in the Brain Stimulation Journal, but I would say orders of magnitude more than what those surface electrical stimulators. So like the Halo Sport, I have one of those to see if it can help me do better at my deadlift. But that's about 2 milliamperes right to the scalp. Whereas the like Neurostar or the BrainsWay TMS devices that I use in my practice, that's a 1.5 to 2 Tesla electromagnetic field that will induce current in the brain. So that's a strong enough stimulation that I can make your thumb twitch, by pulsing over your motor cortex, and then we can use that to treat depression. And I'm for about 4 years now, I managed to boil it down to all I do because I find prescribing and regular old office work boring, and that now I'm only stimulation. Fun thing was I was trained at Naval Medical Center San Diego to do TMS when I was in charge of the ECT department. So that was my birth as an electricity guy.
Yeah, that's interesting. And I saw you went to U shoes, and
Mhm.
I had a military back. I also kind of grew up medically in the military as well, so that's kind of neat to see. As far as the electroconvulsive therapy, you've seen obviously the response to electricity that's been known for, gosh, since we first started studying electricity with the brain 100
Right.
years ago. But I'm just wondering, how a magnetic field, I mean, affects our brain. And that 1 point whatever or 2 Tesla magnets, but that's on the order of what some of the nicer MRI machines are these days. That's
Hmm.
powerful, I'd have to say. Well, this is a topic to say that you don't prescribe medication because there's a lot of people with depressants. I mean, it's one of the commonly prescribed drugs. Do you find that there's any benefit in that, or is it something that you find is there's more negative than positive associated with it?
As far as drugs go, there's benefit, but the efficacy of antidepressant drugs across the entire class is about 30 to 35%, right? And that finally became official in the STAR-D trial in 2006. And the interesting thing is it doesn't matter what drug you use. So if there are doctors out there who swear by one drug that they think is better than the others, and that's actually an illusion. They're all kind of in the 30 to 35%. And only in baseball and psychiatry is a 300 batting average considered good, right? Like but it's where we've been stuck for years and years. So a third of the population can benefit. And there are going to be those people who have one episode of major depression in their life. and they could potentially get started on fluoxetine, be on it for 8 weeks. If they're one of the lucky third, they might achieve remission and get off that drug and be okay. And it's like, congratulations, you just cured depression for $50. That exists. But out of the millions of people in the country who suffer from depression, at least half of them are more in the chronic depression, repeat episodes. The drugs never seem to work forever. And they always end up having to be on more and more drugs, and then start piling atypical antipsychotics on top of that. And that entire class has a black box warning for type 2 diabetes and metabolic syndrome for a reason. So people start going down that road. And I would say that's where we fit in. So yeah, the drugs can help. I've met very, very few people who like taking them, and then most people don't get much out of it for long term.
One of the things about obviously this is a little group of people that eat meat-based diets. I've seen over and over again significant improvements in food, depression, anxiety for many people, PTSD, a lot of things. There's a guy named Chris Palmer out of Harvard who you may be familiar with, who's using ketogenic diets to treat things like I think schizophrenia and some of these other diseases of the mind. Do you find that, well, I guess one of the things I wonder is, why do we see so many people that are depressed these days? Does the environment play a role in that? Have we changed genetically, which seems far-fetched, but what are your thoughts around nutrition and mental health disease, and then why we have such a relative increase in the frequency people are being diagnosed or suffering from these diseases?
I'm increasingly convinced that nutrition is playing a huge, huge role. I agree. I don't think we've changed genetically that much. And that I listened to a lecture maybe 3 or 4 months ago from a guy I really respect. And he said that we have something, 30-40% more bipolar in kids in the United States than what they have in Europe. And he just threw it out there. He says that, that's because we're genetically all messed up. And then he kept talking and nobody challenged him. And I was in the back of the room, like, how could that be true? Like, why in a million years would one of the most mixed societies in the entire world have bad genetics compared to, extremely homogeneous societies across the ocean? And that, to me, that doesn't make sense at all. What I think is much, much, much more likely is that children that I would say are 20 years my junior have basically been weaned on high fructose corn syrup. That I was born in 74, right? So I was one of the early victims of the low fat craze. But my parents still didn't feed me a lot of sugar. It just meant that when I was about 6 years old, I didn't see another slice of bacon until I went to high school, that's traumatic enough. But now it's more like you go like right from the breast to Mountain Dew. And that, the amount of inflammation when we're growing and your brain is that hard up for fat, cholesterol, and some basic micronutrients, I don't know how it's possible that that a brain can grow the way it's supposed to grow if you basically, by the time you're like 6 months old, you just went to a steady diet of fructose and refined sugar.
Yeah, that is, if you look at the formulas, the baby formulas are just sort of awful. When we look at the
Yeah.
three ingredients in there, it's just kind of a shame. And when you look at indigenous populations, I mean, they breastfeed for 2.5 years or something. So obviously most sort of westernized people just can't do that. And so they end up, we put these folks on instead of, perhaps more nutritious food, which I would argue would be animal-based foods. We put them on, grain and sugar and, lots of refined carbohydrates, unfortunately. So they end up with that. Somebody, this is a question from Phil, and it may not be within your purview, but it's a little bit about PEMF, electrical fields, electromagnetic fields versus electrical stimulation for muscle recovery and repair. I don't know if you get outside the brain utilization for that stuff or have much knowledge on that. Is there any improvement benefit between those two?
Well, I think there's benefit, but I would say they're two completely different things. So when you're stimulating brain versus stimulating muscles, I mean, I'm pretty interested in stimulating muscles, but in brain tissue, when I'm stimulating brains, I'm trying to either activate or inhibit the neurons that I'm stimulating. And then the therapeutic effects around the brain are a function of turning up or turning down a particular neuroanatomical area. And we're getting our acute effects that way versus I would say muscle stimulation for recovery. That has so much more to do with, changing the blood flow or sometimes even directly impacting pain. Uh, One little thing that's interesting though, there's a PhD candidate at a university out near me that contacted me because he wants to experiment with using TMS to help people recover who have had a chronic sprained ankle. So he showed me some of his original work that's demonstrating that when you've sprained your ankle once and you're in that category where you're more likely to roll it again and again and again, there are spinal and central changes. So you actually lose a certain amount of central control over the muscles that stabilize your ankle. And he's thinking that if we combine brain stimulation using TMS with the rehab of the ankle, we might be able to get people back to a normally stable ankle and they might not be high risk for rolling it. So ask me again later. That might be my first chance to get out of TMS only for mental health stuff and maybe make an impact in the world of athletes, which would be really interesting to me.
I'm just wondering, because, and I see this, I just want to get your general opinion because how, with regard to the TMS stuff, frequency, duration, how long does it take to change? I guess I don't know if it's a circuitry that is occurring in some of these mental health disorders. And, like I said, if we say that diet has a role, do we have to include diet with that to make this a lasting thing? And then the other thing I would, and if you don't get tired of talking to that, there's a lot of people talking about psychedelics these days and these experiments to alter the wiring in the brain. How does that work on a chronic basis? I can see, like with ECT where you're shocking people, it works for a while, but then I guess assume if they go back to the same old situation, the physiology just recurs. So how do we sort of manage those topics?
Well, number one, I'm super eager for someone to figure that out and prove it because right now we're still stuck in not knowing, like ECT by the numbers, most effective treatment there is, undefeated in 8 decades, but the number of people who are still in remission at 6 months is less than 50%. So that the modern way to look at ECT, you have to do maintenance treatment with ECT if you expect people to stay well. But I've never seen anything that accounts for, like, what if you used ECT to break an episode of depression? And then what if someone did change their diet? And, what if they, at the same time, got their inflammation down to zero and got their, insulin resistance, as close to zero as yours? And, would that change the trajectory of the depression coming back? And with TMS, I think we might see a similar phenomenon. The 1-year data after one successful round of TMS has about 2/3 of people still doing well after a year with no further intervention, that's more encouraging than ECT, but it still suggests that in a large group of people, we're not changing their brain forever. Right? We're bringing about a change that's pretty persistent, but it's not necessarily forever and ever. And one of the questions there would be, what was the pressure on the brain that caused depression in the first place? And what if it was chronic inflammation that is related to excess adiposity, excess carbohydrate intake, vegetable oil intake, and everything else we're interested in, so that I can stimulate someone's brain out of depression all I want. And the minute I stop, that downward pressure just resumes. how could they possibly, maintain a remission for a long, long period of time, no matter how much I stimulate their brain out of it. So I think that's really interesting. I don't, well, it's probably about as hard to study that as it is to study, actual nutrition interventions, right? So maybe someday, if I'm really, really, really lucky, I can make friends with Dr. Ludwig and we can do his 3-month in the resort experiment with the TMS that I'm doing and see if that changes outcomes. Because I think it would. I don't necessarily think a dietary change can always cure some of the severe depression that I see all by itself. But I think if I can use brain stimulation to break a severe episode while we're fixing someone's nutrition, I'm I'm thoroughly convinced that we would probably see better long-term outcomes.
Yeah, I wouldn't be surprised at all with that. I mean, I think it is kind of a holistic approach, I think. And we have so many lifestyle variables that are probably not healthy with what we're seeing now. And I don't know that you may have more business after this coronavirus
Oh,
installation
I guarantee
thing,
it. We'll,
yeah,
we'll be
comes
up to
up.
our eyeballs.
Yeah, we're going to have a lot of mental health problems due to just the fear and anxiety associated with the virus, and then also the people losing jobs and the economic trouble that's going to probably fall after this occurs. Do you know? I understand you had an experience with changing your diet and stuff like that as well. Can you talk about that if you don't mind a little bit?
Yeah, it was kind of all my wife's idea. So and my wife is a Marine. So we have a pretty interesting household with me having been a sailor and she having been a Marine. But she's a marathoner, and almost 2 years ago now, she just asked me one day on the couch what this whole keto thing is about that she's been seeing on the internet. And I kind of rolled my eyes and like, well, it's the ketogenic diet. I learned it in medical school. It's this, that, or the other thing. And is it something you're thinking you want to do? And she's like, no, I don't really see myself giving up beer. And then I know what her thought process is, so I knew not to push it. And I would say about a week later, she asked a more pointed question, and I answered it. And about a week after that, she's like, all right, we're starting this tomorrow. And we cleaned out the whole pantry, and we got rid of all the sugar snacks that runners use, and that all went away. And that was almost 2 years ago, like next month, that we switched over to a ketogenic diet, which I was thrilled to do because in 2004, when I was deployed in Iraq, I went off carbs, and we all called it the Atkins diet. And I figured I can just go to the chow hall and just eat meat and cheese. That's fine. And I never even got sick from it. I adapted to it very quickly. And I knew I was in ketosis because I could smell the acetone coming off me. I never needed the strips. My wife got a little sick with it, but I would say within 3 months, she was running at her baseline. And that year, she beat her personal best marathon ultimately by about 20 minutes. So her performance got dramatically better. And then it was around, I would say, October of that year that we'd been talking a lot about you, right? And me being a rower, I found your records on the concept too right away, right? Because that lives in my world. And she got more and more interested, and we had the same conversation where she's like, I just don't know if I can really eat the same thing every day. And I'm like, well, why don't we do it between Thanksgiving and Christmas? Because no one will be bothering us about food, because we'll be between big family meals for about 4 weeks. So we ate steak every day for about 4 weeks. And I would say 3 weeks in, my beautiful wife looked right at me halfway through a pound and a half of ribeye and said, I don't think I ever want to stop this. and the rest is history. So I haven't really eaten more than, a tiny smidge in a social situation of plant matter in about a year and a half now.
Yeah, and you're still, I guess, haven't developed the scurvy and the gut dysbiosis and the heart attack yet. It's amazing.
Not yet. I have an appointment for my annual physical right after this, and the internist is a little mad at me for my cholesterol, so we're gonna have that conversation but I'm going to point out to them that I've lost 3 inches off my waist, and my blood pressure was never super high, but it's now the best it's ever been. And, I'm back to my 19-year-old dimensions and performing in the gym and in the boat better than ever. And it's like, I want to ask him about getting a coronary artery scan. A, for my own curiosity, but B, it might settle him down, because I'm reasonably certain that it's going to be a 0 or close to it.
Yeah, and I'm not sure. Are you in Virginia? What state are you in?
I'm in Virginia. I'm close to Richmond.
Yeah, I don't know. I mean, in a lot of places you can just get those, even if the doctor doesn't prescribe it. You can just get that yourself. You can just kind of go and order those.
Yeah, my wife looked into it a bit, and I think we can get it at the local hospital. Of course, right now, no. It's like, actually, a friend of mine is a tech in the CT center, and they've shut down everything but stuff that's needed for surgery and chronically ill people. But yeah, it should be something we can get soon, just so I can have that information.
So you kind of touched on this, and somebody asked this question specifically. Are you attempting to utilize nutrition therapy in conjunction with the TMS in your practice right now? And how hard or how successful are you getting people to actually change their diets?
Attempting is the right word for it, and I'm meeting a really impressive amount of resistance. I find that I bring it up when I feel like I have to, and it's one of those conversations I've had with some of the management element in the office that, we're a dedicated TMS center. That's what we do. And I even had one patient complain that I dared to bring up nutrition. Well, okay, this isn't Burger King where, you can expect me to only talk about what you came here for. So, there are times as a physician where I just can't not bring it up. I can tell from looking at somebody that they have type 2 diabetes, and I know it's contributing to their depression. But even after all that, I'd say in 2 years, I've had one patient who took in everything I said, changed his diet. And the good news is he had a wonderful, wonderful outcome. Like, his depression got completely into remission. And this was a guy in his early 30s, and he was probably a good 60 pounds overweight. He'd lost at least 30 of that by the time he finished his TMS treatment. And I only wanted him to stop eating carbohydrates, and then he went full carnivore, which was probably the perfect thing for a single guy who lives by himself. And by the end of his treatment, he was just in wonderful, wonderful shape. So in 2 years, I got one gold medal that I'm excited about. But we'll keep working on it. Eventually, we'll start turning some heads around.
Yeah, I don't know if you're aware. I mean, we've got this. Ludwig's got the study going with the carnivore thing they did. We just launched that the other day, so we are.
Yeah, I saw that.
Really looking for participants, and I'll put my plug in for you guys that are 6 months or more, please. Because people complain that their doctor won't support them, their family won't support them because there's no science, and this is an opportunity to help contribute to that science. And so we can get that out there, and then obviously eventually we get some intervention trials going. That's going to be a big big game changer for getting more people better, I think. Somebody commented that exercise, carnivore diet, and then exogenous ketones have helped significantly with depression. Do you have any thoughts on exercise and supplementing ketones with regard to maybe helping brain inflammation?
I'm so glad you brought that up, because I saw that comment. Like, I gotta jump in and bring that up. Bunch of things. Number one, depression, the end of the comment, depression has a lot to do with brain inflammation. It absolutely does. That's to the point all the cool kids in psychiatry are talking about brain inflammation. So that's becoming mainstream. Inflammation in your body is, by definition, inflammation in your brain. The cytokines get right up in there, and they actually change the entire metabolism in negative ways. One of them is the making tryptophan into serotonin, right? And instead it goes down the kynurenine pathway. And when it goes inappropriately down that pathway, it's directly neurotoxic. So inflammation that goes on for years and years is driving your brain into a metabolism that kills neurons as you go. And depression, anxiety, and probably who knows what else, but definitely those two things. Exercise, exercise is the best anti-inflammatory there is, period. So there's plenty of data out there to show that 15, 20 minutes of what most athletes would not hardly consider exercise, right? So we're talking go out and walk the dog for 15 minutes every other day. And I've seen studies that show that that's enough exercise to change the trajectory of depression. And then, if you can get into the gym and lift weights, well, that's the gold medal. Probably metabolically the best thing you can do for yourself. In terms of lean muscle mass, the best thing you can do for yourself. And you'll also have that effect of reducing inflammation and helping your brain out. Exogenous ketones, I'm going to say they're fine. Though I would still argue that the best possible ketones that you can ever have in your brain are the ones you make yourself. So if you're, with our sympathetic crowd here, if you're not putting the carbohydrates in your body and you're living off protein and fat, then you're making ketones and your brain's getting the best ketones you could possibly get. There is plenty of interesting data, a lot of it coming out of Japan, using exogenous ketones to address dementia, which is very impressive. And and I've seen the pictures of the clock drawings improve from one day to the next. But they're specifically looking at it as an acute, medical intervention without necessarily having to do the dietary change. So it's nice that exogenous ketone is getting that benefit. I would still raise my hand and say, if you gave someone ketones and they got better, step 2 is to take away the carbohydrates so that they're always full of ketones, because that's the best thing you can do. I think final point about the ketones, that I'm also a little bit worried that most commercially available ketones aren't really going to be necessarily the greatest therapeutic ketones. The big ketones that are being used in studies are infusions. So those are exogenous ketones. You put an IV in your arm and you get some beta hydroxybutyrate right in there, or you're drinking ketone esters or something like that. I've been impressed by that, or I've been impressed by the isomer, where it's only the DBHB or something. But then you're talking ketones that cost $30 an ounce, and I just don't know that that's going to be feasible for people for exogenous ketones. Especially when, once again, you can follow a ketogenic or a carnivore diet and you'll be on ketones almost all the time.
Let me ask you a little bit more about assessing brain inflammation. How is that done? I mean, is it it's not just like we look at the C-reactive protein, see it's elevated and assume the brain's inflamed as well. Is there a way to say, is there imaging, or is there some other marker that says, yes, your blood-brain barrier is leaky, or how do we actually test that? Because that seems pretty difficult.
Yeah, I don't think that there's nothing that's really clinically useful. I can sort of fantasize about something being done in the research arena and actually taking fluid. But as it is now, to my knowledge, the only thing that exists in the clinic is looking at all the inflammation markers that you just rattled off. So C-reactive protein, and look at someone's metabolic state. So, in my office, when I'm talking to people, I'm looking at them and they're like, how do you know I'm inflamed? It's like, because I'm a doctor and I can tell from looking at you. It's like, I don't need to get blood off you to prove that you're going to have high markers for it, because clinically I can see all the signs and we don't need to go there. It'd be pretty great to be able to assess the exact amount of inflammation. While we're at it, I'd love to have a good way of knowing insulin resistance in the brain, as opposed to insulin resistance over the entire body. But for now, those are two tools that I don't quite have available yet.
Yeah, so are we seeing just associations between generalized markers of inflammation and these various depression, anxiety, bipolar? Is that correlational data out there at least?
Yeah, that's out there. There's correlational data related to inflammation. There's correlational data related to like excess adiposity. So with like particularly with bipolar, that's a study I was lecturing on, I want to say from 2017, that showed that, bipolar disorder and excess adiposity go together, like cookies and milk, pun intended. And that, going back to probably when I was in residency and when you were in residency, like we were just taught that people with severe mental illness almost always have excess adiposity, which was blamed on the drugs, and they're at risk for diabetes, which was kind of blamed on their genetics, and they're at risk for heart disease, and they almost always die about 20 years earlier, than their cohort that don't have those illnesses. So those facts and correlations haven't changed, but what has changed, and particularly from that study in 2017, now it's more reasonable to suggest that it might not be that people with bipolar disorder are more likely to be on drugs that make them gain weight and not eat right. It might be that the same thing that is making them so metabolically unhealthy is also driving the bipolar disorder. And there's even some evidence of mitochondrial dysfunction in people with bipolar disorder, which again goes back to that idea that the brain might not be able to actually use fuel. So they're not, even when they're getting adequate, fuel, even in carbohydrate in their body, the mitochondria just aren't cranking out the ATP, and their poor brain is in a low energy state and it just can't cope.
Yeah, I think we're seeing just even, just insulin resistance in general, and then a subsequent, diabetic pathophysiology is maybe starting at the mitochondrial level. We see with, incomplete oxidation products occurring, and, these things interfere with insulin signaling. Probably that's occurring in cross tissues, I'm sure. And I don't know what is mitochondrial density in the brain like. I know not certainly in tissue like muscle, which is highly metabolically active. I guess the brain you would assume, because the brain obviously uses a lot of our energy. So are we seeing mitochondrial? I mean, obviously brain biopsy is not always an easy thing to do. But
what? You don't want to sign up?
no, I think there's.
Yeah, I'd say the mitochondrial density should be higher. Because the brain's sucking up about 20% of your total daily energetic needs. It is massive, massive energy hog, and that's also something I've been thinking about more and more. Another one that I don't really know how to study it. I had a wild idea of putting a TMS device in a metabolic chamber and see if we can stimulate brains and change someone's actual metabolic rate, like while we're stimulating their brain. Because in one session, one daily therapeutic session of TMS, I'm making someone's brain fire about 3,000 times in 20 minutes. And I've had about a third of my patients over the years tell me that they feel kind of wiped out after a treatment. And I found it surprising that more people don't feel wiped out after a treatment, because I pointed out to that person, I made your brain crank for a full 20 minutes. That's not metabolically free. It was your energy use went from here to here. But then recently I started wondering, what if those 1/3 of patients who are so tired after a treatment are insulin resistant? They don't have the good mitochondrial function, so that when I artificially increased the energy need of their brain, their body was unable to meet the demand. And lucky for maybe the other 2/3 of people, when I increased the energy need in their brain, the engineers started shoveling more coal in the fire, and they actually got the extra fuel to their brain. And at the end of treatment, they felt okay. But somehow a third of them actually practically feel like they got to go lie down after a treatment because we wiped them out. And then my question after that is, what if I put those people on a ketogenic or carnivore diet for 6 weeks or something like that before TMS treatment, and we reversed their insulin sensitivity, their mitochondria were functioning better, they're fat adapted, they have ketones floating around in their bloodstream, so that their brain now has multiple redundant sources of fuel, which is what it should have. and then I put them through TMS, maybe nobody'd feel tired after a treatment.
Yeah, I'm just a little more on the TMS because again, I don't have a great deal of familiarity with it. How is that employed? Is it electrodes? Is it a helmet? And then what other outside of depression do you have other? Is there other like people using it for other things, performance, weight loss? What do we know about TMS?
Well, what we know is probably a tiny fraction of what we'll know in 5 years. So it is pretty exciting. Every device except one. So there are about 7 or so commercially available TMS devices in the United States, and all but one of them use a figure 8 shaped electromagnetic coil that just sits, right there on the head. So most of the devices, the coil's in a plastic housing, so it's kind of a brick, and it just sits there, and it generates a field that's probably about 2.5 centimeters by 2.5 centimeters, and you can stimulate brain tissue about an inch below the skull as a result. There's one device, the Brainsway device, it's what they call an exotic coil design. And the only way I can describe it is if you can see the coil, it looks like a hat made out of wires. And then it's in a helmet. So that is one device, that it's a helmet that you wear. It's still meant to stimulate the same place when you're using the on-label treatment that all the other ones use, but it's a funky coil design that might do things just a little bit differently. And I use them both. In regards to your question about other things than depression, the Brainsway coil, a new version of the coil with a different design, got FDA approved end of 2018 for obsessive compulsive disorder. So we're using that because we got some of those coils, right when they got approved. We've treated a small number of people. We've had pretty good results. So I would say that's the first time in a decade that there's been a new indication that's actually on the label for TMS treatment. So we had depression since 2008, and then 10 years later, we now have depression and OCD. Everyone and their brother is looking for other ways to use TMS therapeutically. There's been a successful study for substance. So that's a third coil design that you can't get commercially in the United States yet, but they got enough positive result out of using that coil to help people quit smoking that's going to go into randomized control, and they're going to go for the FDA label. Weight loss might kind of fit into that category, right? So any kind of compulsive behavior, I think that addictions coil is probably they're going to try to generalize it across the board. What's really interesting that you mentioned weight loss, I find quite a few people that have our traditional TMS treatment find that they spontaneously lose some weight. And that what I've attributed that to over the years, when we're treating depression, we're treating the left dorsolateral prefrontal cortex. So that there's going to be a quiz later, but that's the full formal name of the anatomical target. That part of the brain is most associated with cognitive control and executive function. So my hypothesis with the spontaneous weight loss that a lot of our patients see has to do with improved impulse control that they're not aware of. So I suspect that over the course of 6 weeks of treatment, they're not eating nearly as many cookies that they never knew they were eating before, because they're just doing so much better of a job of basically saying no and sticking to what they told themselves they were going to do. But since they didn't really know how badly they were eating before, they feel like the weight loss is magic because they don't understand what they're doing differently.
Yeah, this is a question that I don't know if, these genetic mutations, there's so many of them now, and it's hard to really keep. Well, somebody's asking about the PPAR alpha gene mutation and its sort of interference with creating endogenous ketones. Do you have any insight into that or any thoughts on where that could potentially have an impact on, I guess, mental health?
That one I don't. Ask again later. So
like I said, there are literally thousands upon thousands of these genetic mutations, and they'll have these names you can never keep track of, and so it's interesting. Any evidence of TMS being efficacious in perhaps like TBI, brain injury, or even spinal type of injuries? In the other.
Maybe that. So again, the Japanese have been studying TMS pretty heavily in stroke rehab. So that was sort of the first indicator there. And what I read is that they were actually getting people into TMS within 48 hours of an acute stroke. So someone comes in, gets a stroke, the minute that it looks like the stroke is stabilized, they're getting them under the magnet. And that has to do with increasing neuroplasticity and increasing neurogenesis, and actually an increasing BDNF, which is something that TMS seems to do, and putting that brain into a state that it can begin to fix itself and rewire itself more effectively. We're doing quite a bit of TMS in my practice in the traumatic brain injury population, but that has more to do with the traumatic brain injury population having depression, which they almost always do. And in the TBI population that have depression, the drugs like never work. And that's been in the literature time and time again. Sadly, there's no guideline suggesting that you should skip the drugs in someone with a TBI. So they still go through all the drug trials before they come to me. But we've been getting really good results, about as good as my general population with the TBI population for depression. Interestingly, I've seen like one paper so far in using TMS to treat TBI in general, as opposed to trying to treat depression in the context of a TBI. Same thing. I have to believe it would be a positive influence. There just hasn't been that much data put out there yet.
I guess there's a question about fasting and why it seems to be helpful, or I guess fasted exercise. Do you incorporate that in your own personal life, or does it come up with any of your clients?
Doesn't really come up with my population at work, though. When that New England Journal of Medicine article finally came out about intermittent fasting, it's like now I have that appeal to authority, so I wave that paper around on a fairly regular basis, and start encouraging everybody I can in the office to start limiting their eating window, to 8 hours or less. If I can't get them to change their diet, but I can get them to do that, and that might actually start being a gateway. If they feel better because they did that one thing, then maybe they'll listen to me about something else, and I can get them off the sugar. Me personally, I think I've always trained fasted when allowed to. So except in high school when my coaches made me eat before I got in the boat, because they're like, breakfast is the most important meal of the day. But left to my own devices, I would always get in the boat or get on the weights, before I ate anything. So learning about fasting just validated that for me. And now I train everything fasted, and even better, just another one of those, wonderful benefits of being fat adapted and being carnivore. Last year in the fall, in fall races being head races, so a full 5K, I raced three times in one day with my buddies. So 5K and then another 5K an hour later and another 5K after that. And I raced fasted the entire day. I never really felt like I had to put anything other than salt water in my mouth to keep going out there and just racing over and over and over again. And I felt great, and we won at least one of them, if I remember correctly.
What size boat? How many people in the boat on that one? Was it 8 or 4?
Those days we were in a quad.
Okay.
So my boat club here in Virginia, the VBC, Virginia Boat Club, we're pretty small, and there's, from the competitive squad with the men, I would say there's no more than about 6 or 7 of us that are, experienced rowers who literally show up at 5:30 every morning and to race. So for a few years now, we've kind of had the perfect number for fielding a quad, and we're, get out there and train every day. So we had a really nice outing in the summer a couple of years ago, and raced at Masters Nationals in Worcester and did quite well. And then the fall race last year. And then now, at least for now, we're not training, and I'm a little worried that the whole racing season is probably going to get canceled. So which I guess that means I got another year to put on muscle before I got to go out on the water and prove the benefits of the carnivore diet.
There you go. I don't know if you have a concept two at home, but obviously
Oh, I
the,
do. Oh, I do.
yeah, yeah, I'm on mine most days. So
Hmm.
somebody's asking about Tourette's syndrome. I don't know if you deal with Tourette's very often in your practice, but could TMS, I mean, obviously maybe potentially benefit that, or have you seen it benefit that?
It can, and I have. It hasn't come up in my practice very often. Yeah, number one reason for that, the treatments that are off label, insurance companies usually won't touch it. So then it by definition ends up being something that's out of pocket and kind of expensive. So that tends to really limit, that I think we've just taught the entire country that they shouldn't spend money on their medical care. So it's like a lot of people won't consider it. But TMS for Tourette's disorder was studied specifically by a guy named Montavani in Colombia. So Montavani, I think, Montavani. And he published 6 or 7 papers specifically stimulating the supplementary motor area at a low frequency in a way to shut it down, and got pretty good results with Tourette's. And what that led to was my favorite case of all time in my TMS practice. I treated a 9-year-old boy whose dad brought him to me. And that poor little, they had to take him out of school because his tics were getting so bad. And he was having abdominal ticking episodes that would go on for an hour, like doubled over and grunting. And then he'd have to go to sleep later. And his dad was actually hooked up personally with Montavani, came to me with a TMS protocol that Dr. Montavani wrote out for him and said, see if you can get someone to do this for you. So he came to me, he's like, would you do this? And I said, heck yeah, I'll do that. And we had to put 3 phone books under that little boy's butt to get him up to the magnet, because the chair wasn't designed for kids. And I'd say within 2 weeks, he was having entire days tick-free, and his parents were over the moon. We had to treat him on a maintenance basis. We found, no matter how many treatments I did, if we stopped, the tics would slowly come back. We got down to where we could treat him once a week, and he was pretty close to tick free. And then after a couple of years of that, what I think happened is that his Tourette's spontaneously resolved, which is what his dad was hoping for. That if we could manage it for a couple of years and he didn't have to take drugs, and then he might just, grow out of it and get better. So his mom still sends us pictures of him. He's a teenager and he's playing tennis in school now. He's great. So my favorite all time.
That's wonderful. Hey, let me ask you about this the TMS. I mean, what insurance covers it? I mean, for what indications, and how widely practiced is it throughout the US and maybe other parts of the world? Is it hard to find a TMS practitioner in most parts of the country?
I'd say it's getting pretty easy. So for depression, like the original FDA approval, every commercial player covers it. Medicare covers it. TRICARE covers it. Most of them have pretty clear criteria. They want you to try a couple of medications first, but those rules are laid out. So at this point, with that coverage for depression, when someone comes to see me and they check those boxes, we send up a request. We usually get approval for the whole course of treatment within 72 hours, and no problem. And it just depends on what their copay is, how much it's going to cost. As far as how widely available it is in the United States, it's our company, we're north of 100 centers now, because our goal is that everybody in the country should be able to drive fewer than 20 minutes to go have TMS. I mean, so we've been just growing and growing and growing for years. But I would say anybody in every state can find a practice now, even if it's not us, that is probably no more than 30 minutes away from their house. So it's not that hard. It's still, what with, again, close to 15% by some estimates of the population suffering from depression. And I think 2 or 3 years ago, TMS, there were like 25,000 treatments done in the entire country, which is just the tiniest fraction of people who could actually benefit from this treatment. So we still have a long way to grow. And psychiatrists are not referring people to TMS even close to early enough. People are taking drugs that aren't really working for years, before anybody even brings up any kind of escalation in their care. But that's what we're doing. We're trying to solve that problem. OCD, the other FDA approved, is so new. We are getting it covered by insurance, but it's still in the case by case by case basis. So people come to us for an OCD consult. We make the request. I'm going to say about a third to half of them actually get covered, even though the insurance companies don't have a policy. So what happens is someone comes in, I send the request to insurance, and then one of their doctors calls me and says, "What the heck is this?" and I explain it to them, and then they think about it, and about a third of the time we actually get approved, and the rest of the time we get flatly denied because they're like, "We don't cover that." It took about 3 years for depression TMS to get like real coverage with insurance. So I'd say in about 2 more years, OCD, there's probably going to be policies with rules, and then that'll get covered a lot more widely too.
Just two more, I guess, off-label thoughts. One person was asking about things like chronic pain. We know some of the pain perception is modulated in the brain, and then
Yeah.
PTSD. Are any of those been utilized? Have you utilized that for any of those indications?
Yes. Chronic pain, I've had some great results, and it's published too. I didn't just make it up, but stimulating the motor cortex has resulted in some pretty great outcomes with chronic pain. Probably, I think right now the prevailing hypothesis is that you're not really stimulating the motor cortex. You're stimulating the thalamus by way of the motor cortex. And if you can modulate the thalamus, it seems to be able to modulate a lot of people's pain experience. So I've done that in the clinic, and it's worked out pretty well sometimes. So that's a thing. As far as PTSD goes, in this last year, at least one of the manufacturers was getting ready to get a PTSD study off the ground, and then in their preliminary data, the treatment failed versus sham. So that was very disappointing. They flushed that, and everyone's sort of back to the drawing board. That said, my first big use of TMS treatment after I got out of the Navy in 2011, I came to Richmond out of the Navy to run a military-focused PTSD program. So that's why I moved here in the first place. There was a 28-day elective residential program where we're doing exercise in the morning and yoga in the afternoon, even though the Marines hated it, and two group therapies a day. And when I got there, I convinced the CEO to buy a TMS system, which is like literally the first and only time any CEO ever listened to me ever. But he bought a system, and I started treating everybody there with PTSD, but I was using the standard on-label treatment for depression, and I saw great results across the board. And that, in retrospect, I think it could be one of a couple things. It's like, number one, depression, and PTSD is depression with a lot of other stuff, added on with the anxiety components and hypervigilance. And before 1980, when PTSD actually became an official name diagnosis, you would diagnose someone with anxiety and depression all in the context of a traumatic experience. So right out of the gate, I argued that I'm not purporting that I'm using TMS for PTSD, but if I can make a dent in the affective symptoms of PTSD, then everyone's going to be better off, and they can go to their group therapies and work on all the other stuff. I got such good results that in retrospect, I think that maybe TMS on my patients made their cognition better and their brains more plastic. And I'm wondering if they actually functioned better in therapy. And so I not only helped get the depression off the table for them, but I think we might have been enhancing their psychotherapy and exposure therapy responses across the board. Maybe. So if I could go back in time and track that better, then maybe I could prove it. But for now, it's like we had good success. So if anybody ever asks me in the clinic, do you do this for PTSD? My answer is like, not officially, but we'll do it for depression, and you'll be glad we did. because you'll probably end up with a net improvement no matter what.
Yeah, I guess one final question as we have time for. Stephen's asking, I guess, is there any brain imaging that shows pre and post treatment? You know, I guess functional MRI or PET scan or something you could look at to see changes?
No. Now that's a very, very qualified no. And that one of the manufacturers, Neuronetics, they use a functional MRI scan in their advertising that drives me crazy because of that advertising they do. I get asked on a fairly regular basis in clinic, like, why don't we get a pre and post functional MRI? And I'm like, because it'll cost you 10 grand, you know, that you'll never get back and it won't prove anything. Where the functional MRI with TMS is like, if you did functional MRIs for 1,000 people who all went through TMS pre and post, you're going to see something that, you know, would prove for the purposes of the study that you made a change. But for one individual person, right now, a pre and post functional MRI is not quantitative enough that it will actually show like what we did. There's some people out at UCLA that are trying to use functional MRI to guide TMS treatment. So they think that if they get like a functional MRI, or maybe even better, a functional connectivity MRI, they can actually show what is dysfunctional and then specifically use that to navigate and treat that specific area and correct what they've proved as a problem. What I see from that is that they've been doing that for 2 years and haven't published anything. So I don't know that. It's very frustrating, but so far I don't think they've proven that using thousands of dollars worth of functional MRI is really changing their outcomes enough to make a big deal out of, you know, changing the way that we do TMS now, which is simply presumptively treating our anatomical area when someone has clinical symptoms of depression. So that everyone's trying to find that, you know, so far, no.
Well, I'll tell you what, we've come to our hour. This has flew by. There's such great information. Thank you so much for coming on. It's a pleasure to talk to you and meet you. I'm sure everyone enjoyed this and got a lot of information out of this. Where can people find you if they wanted to find you, either on social media or in real life?
On social media, they'll find me at Wiley Liam, WILY WYLYLIAM. I just typed it in the chat so people can read that. And that's Twitter, that's Instagram, and mostly I'm just taking pictures of my Concept 2 and the steaks that I eat. So because I want to be like you when I grow up. And then for TMS, they'll find us at greenbrooktms.com, and that's you'll find where we are all over the country, not just me. So as a TMS resource. I got one 10-second question for you, Dr. Baker.
Sure.
If I come out to Long Beach, could I ever get you to get in a boat?
Yeah, I'd jump in there. We might tip over, though.
I promise I'll teach you.
One time I'd be happy to do that because I've done so much. I've sat on the erg so much. I've never really tried to get in a boat other than a little, an old-fashioned rowboat. So maybe one day, yeah, absolutely.
Yeah, I'm not as big as you, but the two of us in a double, we might just win because everybody else would quit.
I don't know.
I'm 6'3" and 220. It's like I can hang.
Good for you. All right. Well, I got to run. I'm going to end this for everybody. You guys, thanks a bunch. Y'all have a great day and stay safe. All right. Thanks, everybody.
Thanks for having me.
No problem. Bye-bye. Thank you.